One of the most popular sayings in the medical fraternity is that a good surgeon knows when not to operate. When it comes to cancer care, treatment and management, this saying is even more relevant. In this episode, we discuss the reasons for surgery in cancer. When is surgery needed? When is it not necessary? And who are the specialists who do this? And what are the cost implications? I'll be sitting down with Dr. Eric Hungu, who is a surgical oncologist, and Dr. Daniel Ojuka, who is a breast surgeon, just to give us an understanding on when surgery is needed and the side effects and the intricacies of managing cancer using surgery.
When were you told that you had cancer?
That was in 2012.
At
2012.
At that point when your doctor tells you this is the diagnosis, what goes on through your mind?
Well, for me it was not so much because I didn't have any feeling that I was sick. I just went, I had a lump and I went to hospital. I assured the doctor that lump. He touched and told me, Grace, this is fat. As you can see me, I can't lack that. So he said, this, I can assure you this is fat, but I'm sending you to a certain hospital. You go there and have this done. So I went to that hospital. They looked at that lump, and a doctor recommended that I be done biopsy. Biopsy is taking some part and then going to the lab for checking. So actually that was not done. The doctor decided we just cut, we do away with that lump. So we did a minor surgery. He removed the lump and took it to the lab. Well, it was found to be having cancerous cells. So now I was to go back for the results. So when I went back, somehow I managed to go to the lab. To the lab, I got my results, and I read the results before seeing the doctor. So I was there. Then I'm like, me? Cancer? No. And if cancer, I'm going to get healed. So I waited for my turn. The doctor came. I went in, and I could see the doctor was very uneasy. He had brought a healthy nurse to perhaps get hold of me when I fall down. So I went in there, so he's like, Grace, how are you? I'm fine, doctor. Just take a seat. I sat. So, you know, sometimes people get sick. And what I told him, doctor, let's cut a long story. I've read my results. So he's like, really? I said, yes. So now it was easy for him to tell me. So, okay, if you've seen that, I'm grateful. This is what it is.
How was the treatment?
Yes.
When you started treatment, how was it?
You see, now the first treatment was again to go for another surgery now called mammogram. No, mastectomy. I went for a mastectomy, and now after that, I was to start chemotherapy.
How did you take the news of the mastectomy?
You know, I'm a woman, and that's a sensitive operation. But then I said, if it is healing me, let it be. And it did. It healed me, and I let it be. And here I am.
Are there times when you unasikia ni kama hutaki safari tena?
Well,
at times you give up.
As a human being, sometimes you see like it's kind of unfair, but then you say, if you want to live, you know, so you say, I'll go through it.
Okay.
My name is Dr. Eric Hungu. I'm a general surgeon with a subspecialty in breast oncoplastic surgery. So that means I deal with patients who have breast cancer. Yes.
All right. So can surgery treat cancer?
Yes, it can. It's one of the modalities of treating cancer. So cancer treatment is multidisciplinary. There's usually surgery, there's chemotherapy, there's radiotherapy, there's also hormonal therapy, depending on the subtype of cancer that we are talking about.
When do you do surgery for cancer, and what options are there?
So surgery for cancer is one of the treatment options where if you're able to define the lump well, and one of the key things that we look for is that you're able to remove the whole cancer and be able to close the skin so that you do not leave an open wound. That's usually the ideal scenario. So it's possible to operate all stages of cancer. So if it's early breast cancer, you can do surgery that can be either mastectomy, that means you remove the whole breast. You can do what is called a breast conserving surgery. That means you just remove the lump, and then you have enough breast tissue, and you can reconstruct that breast to make it look a bit more cosmetic. If it is advanced, if it is a big lump, if it's like a T3, T4 tumor. That means if it's bigger than 5 centimeters or if it's ulcerated, there are the options where you can start with chemotherapy. We call that neoadjuvant chemotherapy. That downstages the tumor. And then when we go for surgery, we are able to get good margins and skin closure.
What do you mean by downstaging the tumor?
Downsstaging basically means that you reduce the size. Sometimes with this chemotherapy, the tumor, the lump can even disappear. But we usually advise our patients that that doesn't mean that it's cured. They still need to come back for surgery. Because if they go away after the chemotherapy, they don't come for surgery, the tumor can grow and it will come back bigger and it will be harder to operate. So that's surgery on the breast. There's also surgery in the axilla. That's the armpit. So usually advise our patients, cancers, the first place it spreads to is the lymph nodes in the armpit. So when you examine, sometimes you can actually feel the lumps, the lymph nodes. So if they are big and they are obviously palpable, we do what is called an axillary dissection. But if they are not palpable, what we do is what is called a sentinel node biopsy. That means we inject either a dye or a radionuclide marker so that we pick the nodes that exhibit that dye or that marker, and we send them for testing. And then after that, patients can come for adjuvant treatment.
But that is for breast surgery?
Yes.
And for any other cancers that may appear in any other part of the body, is there a role for surgery?
For most cancers, there is a role for surgery. The only time that maybe you can say there is no really a role for surgery is if the cancer has spread to other organs. That's what we call now stage 4 disease. It can spread to the liver, it can spread to the bones, to the lungs, so that makes it challenging. But surgery might still be an option to do what we call local control of the disease. But then again, there are some other types of cancers where even if it has spread to other organs, especially the liver, that's like colon cancer. If it has spread to the liver, you can actually go and remove those metastatic nodules if they are not too many.
So what's the advantage of doing surgery when you're trying to treat or manage cancer?
Some cancers are potentially curable, especially breast cancer. If they come to us early, it's still confined to the breast. It hasn't spread to the lymph nodes or to any other organs. If we do surgery, it is a potentially curable disease. So that's usually the advantage. Sometimes the advantage might be what I called local control earlier. So I'll talk about breast cancer because that's my area. So sometimes you find the tumor is so big and it makes the breast very uncomfortable. Sometimes it ulcerates, it's bleeding. So after you try to downstage it, then you do that local control. It gives some quality to life.
So is there any part, like you can have one can undergo chemotherapy as part of palliative care. Is there such role for surgery for palliative care?
I was actually in a meeting in the ministry last week. We are trying to develop some guidelines for management of cancer. And they said palliative is usually not, well, we usually misunderstand what palliative means. Palliative starts at the first point of diagnosis of the patient. So basically it's a continuous process. What people think is palliative is usually end of life care. That's hospice care. And that's why we try to make the patient comfortable to give quality of life rather than just giving medical interventions that might not add value. So sometimes you can actually say that surgery is palliative up to an extent if you're trying to do local control, that debulking sort of surgery. Yeah, it's not curative. The patients need to understand that it's not curative. The relatives need to know that it's not curative. We're just trying to make life a bit more comfortable. Because if they have all that bleeding and that pain, it might make life a bit better. Yeah.
And at times, people may think, or from some experiences, that when they have a surgery for cancer, then it makes it worse or it spreads some more. Is this the case, or are there instances like that?
That's actually a very common misconception, and it starts with, because before you diagnose cancer, you have to do a biopsy. So the biopsy means that you come in with a needle, what we call a core biopsy. Come in with a needle and take samples of that tissue. As long as we are able to get margins, and that's why I say it's potentially curable. If you're able to get margins, then that means if you're able to get the whole tumor out, then you're okay. You're safe. But instrumentation doesn't necessarily mean that the cancer will spread faster.
But are there instances of, let's say for breast, for example, where if you operate on one side, then you find there's a tumor on the other side?
It could happen. It does happen. But that is not because we did the surgery. It means that they're basically getting another cancer on the other side. The whole pathophysiology of cancer is poorly understood. Basically how it comes about is poorly understood. We just know some of the risk factors, but explaining it completely and comprehensively is still a work in progress. But some people have that familial risk of getting breast cancer. So ideally, in some people who you suspect that that trait runs in the family, you should do some genetic screening. And then where I train, sometimes we would offer patients bilateral mastectomy if you think they are at an increased risk of getting that breast cancer. Bilateral mastectomy means you remove both breasts. Now, an option that I didn't mention about surgery is that there's an option for reconstruction after surgery. But that's after we are sure that we've treated and the disease hasn't come back. We can do reconstruction with the help of plastic surgeons.
So, what do you mean by reconstruction?
So there are different types of reconstruction. You can put implants. You can put like silicone implants, or you can use the patient's own tissues. You can take some muscles and you rotate them upwards or sideways, and you just create a new breast. Yeah.
And what are some of the questions, some of the fears that patients have when they come to you and they're scheduled or they are candidates for surgery? What are some of the questions and fears that the patients have?
Our patients are very religious. So when they come to us, they usually say, it's all in God's hands. You do your best, and we leave the rest to God. I suspect the oncologists are the ones who get most of these fears, because I know sexual function is a big concern of some of these patients. But for surgery, especially we do surgery in the armpit, I usually tell them you might get some numbness and some pin and needle sensation on the arm where you've done that surgery. So sometimes they can be concerned if they will be able to regain full function. And it is possible to regain full function. You just need to start moving your arm early, start using it early. Yeah.
So that's for the breast. What are
the other areas?
Yes.
So like, I'll give an example of colorectal cancer again, because that's another common cancer that we see here. So sometimes when you do surgery, you're not able to reconnect the intestines. So we have to give them what is called a colostomy. So a colostomy basically is when you bring out part of the gut onto the anterior abdominal wall. I don't know the layman's term for that. The abdomen. Yes. Yes, to the front of the abdomen. Bring the intestines out onto the abdomen. Yes, to the front of the abdomen. So for colorectal cancers, some of the treatment options include when you're not able to reconnect the intestines, one of the options is fashioning a colostomy. That basically means you bring out the intestines onto the front of the abdomen. So that's where the stool will be coming from. We usually provide them with bags which can collect the stool, and there are some stomach care nurses who can advise them on proper care of the stomach. So sometimes colostomy, the opening of the intestine. Sometimes we do that as a temporary measure. Then maybe we might be able to go back and reconnect. But for the most part, if the cancer in the colon is lower down, we might not be able to preserve that function. But other than the stoma, nothing else is affected. Another cancer, this is more for urologists, is when they have prostate cancer. And either they can go for surgery or they can be given medication. Another big concern is loss of sexual function. But those issues are usually addressed with some medication and some counseling. Yeah.
And what costs do people look at when being prepared for surgery?
Well, in public hospitals, if you have an HIF, it pretty much takes care of everything, from the cost of surgery to the chemotherapy and radiotherapy, if I'm not wrong. In private hospitals, depends on the type of private hospital you go to. Some are more affordable than others. And NHIF also does pay, but not the full amount. So they'll pay some amount and then the patients have to top up the balance.
In terms of figures, what are we looking at?
Sure. I don't know. It could be anywhere from, I think the minimum you might pay is maybe 250,000 shillings. Because you have to include the cost of theater, cost of hospital stay. If a patient needs to go to ICU after surgery, then the costs will definitely increase almost exponentially. But that is just for surgery. After that, if they need chemotherapy and radiotherapy, those are increased costs. And then they will also need occupational therapy and physiotherapy and counseling. So maybe for the full treatment, probably 1 million shillings plus.
And does the other, because some patients may require surgery, chemotherapy, and radiotherapy all together. Does any of them make the other worse?
Not really. They usually like...
in terms of treatment and side effects and whatnot?
So the side effects are specific to each, but all these things are, I don't know what the word is, maybe symbiotic. They help each other out. So like when you do chemotherapy before surgery, it reduces the size of the tumor, so you're able to get it out. And then you do surgery, you get it out. And then afterwards, you give radiotherapy. So radiotherapy basically means you're hitting that area where you've done the surgery with radiation. So to prevent recurrence of the tumor on that site. So they all work together to help eliminate the disease. So this lady has a breast cancer on the right side. It's an early stage cancer. It's what we call a T1. And she doesn't have any palpable lymph nodes. So that's what we call an N0. So the surgery we are going to do on the breast, is a mastectomy. And then for the axilla, we are going to do what we call a sentinel node biopsy. So it's just injecting the methylene blue dye so that it can go to the lymph nodes under the armpit. So the ones that take up the dye are the ones we remove. So this is better because it gives less complications after surgery. So the arm swelling, the numbness is much less.
I see she's had another surgery before.
Yes, she's had surgery on this other side a few years back, and it's not because of the surgery that she got cancer on this side. She's a young lady, I think she's in her 40s. So ideally, this would be again someone who you would like to maybe do some genetic markers.
So was it also cancer on this side?
Yes, it was breast cancer on that side. Yeah.
So what do you plan to do exactly?
So in an ideal scenario, in a patient who this was the first time she was getting cancer, and it's this early, we would want to do a breast conserving surgery. So we just remove the tumor, and we remove the affected lymph nodes, and we leave her with her breast. But since she had cancer on one side, for cosmesis, so that she's asymmetrical, and also she looks like, we haven't done the genetic testing, but she's at a higher risk of getting this cancer, so we have to remove the whole breast. The surgery might actually make them worse. So there are some surgeries that might not be operable, like if you're talking about cancers of the liver and the biliary tract, some of them might be inoperable. There are some cancers in the pelvis and in the abdomen, maybe they might be so advanced that you're not able to go in and get the tumor out, and even giving chemotherapy doesn't reduce the size. So in such a scenario, I don't think there's much that we can do. Yeah.
Anything else you want?
Well, we have the Surgical Society of Kenya. That is the umbrella body for surgeons. And in that society, there's different committees. And one of the committees is tasked with improving quality of care for cancer patients. So that, in conjunction with the Ministry of Health, we are trying to come up with proper workable guidelines for management of these cancers in the country.
Thank you.
Thank you.
Health Digest takes a brief break, and when we come back, we continue with this discussion about surgery in cancer care and management.